أي مكان.
السلام عليكم ورحمة الله. We'll start our lecture about management of normal labor. We knew that normal labor is divided into 3 stages. The first stage starts with diagnosis of onset labor, ending in full cervical dilatation. Second stage starts with the full cervical dilatation, and during this stage the baby is delivered. The third stage is the afterbirth, which is the delivery of the placenta and membranes. We know that during the second stage there are certain actions happen, mechanism of delivery of the baby. First start with the descent due to the labor pain that increase throughout the period of labor. The descent will make the baby engaged and enter the pelvic inlet. In the pelvis, which is a special cavity with special shape, the baby's head is taking certain action. In fact, 2 action: the flexion, or increasing the flexion, which is already flexed, but when it enters the pelvis, it increases its flexion, and due to the what's called lever action over the atlanto-occipital joint. Then the other movement that the baby head is taking is the internal rotation of the fetal head due to the difference between the anterior-posterior diameter of the pelvic inlet and the transverse diameter. So descent first will make the baby's head pushed from the abdominal cavity into the pelvic cavity. In the pelvic cavity, the baby will take 2 action, or the baby's head is taking 2 movement, which is increased flexion, then internal rotation. The increased flexion is due to the lever action over the atlanto-occipital joint of the fetal head, and the internal rotation is due to the difference between the distance of the anterior-posterior diameter of the pelvis and the transverse diameters of the pelvis. After that, now the head is inside the pelvis. The head will try to be pushed out the pelvis into the exterior. Then it's a new cavity. First the abdominal cavity, and by descent it will enter the pelvis, will have flexion and rotation. Then after getting out of the pelvis, these 2 actions, which are flexion and internal rotation, shall be restituted into extension. The flexion will be extension, and the internal rotation of the head will be restitution. Restitution means getting back the position of the head over the shoulder, which is perpendicular position. Then after, now the head is already delivered, the rest of the body will be shown as external rotation of the fetal head, but actually the external rotation of the fetal head is a interpretation of the internal rotation of the shoulder. In fact, the idea of management of normal labor is try to diagnose labor first, then monitoring the progress of labor, ensuring the fetal and maternal well-being. How to diagnose labor? Diagnosis of labor will depend on 2 symptoms and 2 signs. The 2 symptoms are true labor pain, which is frequent suprapubic colicky pain, true labor pain, and complaining of a show, which is a bloody stained cervical mucus. These 2 symptoms are important for the physician to start to examine the patient and find another 2 signs, which are formation of bag of water and cervical changes into dilatation and effacement. So the 2 symptoms are true labor pain and show. The 2 signs are formation of bag of water and cervical changes. These 4 items will mark the diagnosis of labor. And after diagnosis of labor, you have to mark also the beginning of labor, because each stage of labor is timed stage. Timed. The first stage is about from 8 hours in multipara to 16 hours in prime gravida. Second stage is from 1 hour in multipara to 2 hours in prime gravida. The third stage is about half an hour. So all these stages of labor are timed stages. How to manage the first stage of labor? First, you have to examine the patient, uh, the engagement of the head, and of course, we know the rule of fifths, and this slide shows exactly the role of fifths, how to be sure that the head is engaged or fully engaged or not engaged at all. The vaginal examination in order to assess cervical condition, and we know also Bishop score, which assess the cervical condition, and it's very important as a step of induction of labor. You have to assess also the membranes, which is intact or not intact, and the cervix, as we said. And here is a slide which show the effacement of cervical canal. Effacement means loss of the canal, loss of the formation of the canal. In the beginning, in the upper left quadrant, we know we can see the cervical canal very well. When this canal is lost, that means effacement. And according to the degree of loss, also comes the degree of effacement. And also we have to determine the pelvic inlet and outlet and the pelvic cavity by our examination, which we call pelvimetry by the examiner's hand. And of course, the vaginal examination should not be done in a placenta previa when the placenta previa is suspected. Of course, we have to do this with completely aseptic technique. You have to prepare this patient and encourage her to evacuate bladder rectum during the first stage. Of course, we have to make sure that completely aseptic technique during the first stage, which is a very long stage. Maybe it takes about 16 hours in primary gravida. And of course, during this stage, we have to monitor the progressive labor, which is very important. And there are several establishments to monitor the progressive labor. The most common and approved by WHO is partogram. The partogram is a sheet of paper. It has many information about the stage of fetal head, the stage of fetal heart, the cervix, the membranes, and the contraction of the uterine muscle, and of also certain measures about the vital measures of the mother and urine output. The most important thing is how to follow cervical changes and descent of head in the second part of the paper. And you see a line called alert line and a line called action line. And this indicate the Friedman curve, as we know that the cervix is dilated according to Friedman curve. In the first half of the 16-hour first stage, the dilatation is slow, and it starts from 0 dilatation to about 3 centimeter dilatation in an 8 hours. The whole half length of the second stage, only 3 centimeters is dilated. But the second half of the first stage, the rest of the dilatation occurs into some sort of increasing the pattern of this line. We have two definitions which are important. What's called management of normal labor and active management of normal labor. Management of normal labor is just a follow-up of the progress without any interference from the physician. But active management of normal labor, which happens between the alert line and action line, which means that the physician will have to interfere. What are the interference of physician in the period between the alert line and action line? Is two interference. The two interference starts with the letter A. The first amniotomy, which artificial rupture of membrane. That means when the patient gets to the alert line after this period of time and never reached the full cervical dilatation, that means I have to interfere, that I have to transfer the management of labor into active management of labor. And again, active management means two interference mainly. The two interference starts with the letter A, amniotomy, artificial rupture of membrane, in order to decrease the power of labor pain. And the other A letter stands for augmentation of labor pain by oxytocin drip. So when the cervix when the line cross the alert line and the cervix is not yet get the dilatation at its time, so I have to change the strategy into active management, amniotomy and augmentation of normal pain. And if I did amniotomy and augmentation of labor pain and yet the cervix is crossing the action line, so I have to do cesarean section. The rest of partogram stands for several information about, as we said before, maternal vital measures, uterine contraction, which is marked at the third part of the paper sheet, according to the power of uterine contraction, which is felt digitally over the abdomen of the mother. The drug given should be recorded, and also the vital measure and urine output of the mother. As we said before, the condition of the fetal heart rate and membrane, the molding, shall be presented as as seen in the slide. And here are the difference between the alert line and action line, and this area between the alert line and action line we have to do active management of labor. Then the management of second stage of labor is as we did in the first stage. The first stage we had to change the clothes and get diagnosis of onset labor and monitor the progress of labor, monitor the fetal being and the maternal being. The second stage of labor we shall transfer the woman from the ward into the operation room, and we have to put her in special position in order to let her bathing through the second stage. We have to do perineal cleansing, of course, in order if we are doing episiotomy or not. In fact, during this second stage, the actions we have said before happened, which is descend, internal rotation, flexion, internal rotation, then extension and restitution, then external rotation. This action happened during the second stage of labor. During the delivery of the head, we will do certain actions in order to assure that there are no complication over the perineum, especially perineal tear. We have to do what's called Ridge's maneuver and episiotomy. In fact, Ridge's maneuver is appeared in this slide. one hand is pressing the fetal head in order to maintain flexion. Of course, during this time, the head will show extension to because he had already taken a flexed attitude in the pelvis. When it gets out, it will try to relieve itself from the flexed attitude by extension. So I will not make the fetal head do extension in order not to tear the perineum. So I keep by my right hand the baby in the flexed position in order to bring the smallest anterior diameter of the fetal head. So I have to keep by pushing the head down, I have to keep the head in the flexed position. The other hand is doing a perineal support, and this is called Ritchie's maneuver. Then after that, after delivery of the head, I have to deliver the anterior shoulder, then the posterior shoulder by lateral flexion of the trunk of the baby. That means pushing the fetal head toward the maternal abdomen. Then after delivery, we have to wait from to 10 seconds in order to cut and clamp the umbilical cord. Episiotomy, which is important. Episiotomy is a surgical incision to the perineum, like I'm doing iatrogenic tear, but it's not a tear; it's a surgical incision. So it will be defined as a certain distance and controlled. As I always say, it's a controlled perineal tear, not tear, of course. It's incision, so I can control its distance. I can control its depth. Other than the perineal tear, which can be having that we cannot control its distance and its depth. So it's important to do episiotomy, which is a tear already, iatrogenic tear, but not tear. It's controlled incision. You know that benefits prevent tearing, speed up the pulse, protects against incontinence, protects the pelvic floor muscle, and heal, of course, easier than tears. Of course, there are certain indications of episiotomy: large shoulder macrosomia, shoulder dystocia, instrumental delivery using forceps or ventouse, breech presentation, and then the care of newborn, of course. Management of third stage is delivery of the placenta and the afterbirth, and the repair, of course, of the episiotomy. We have to first to diagnose the perseveration of placenta. And diagnosis of signs, there are signs of placenta separation, which are uterus becomes globular and hard, sudden gush of blood, the cord is called lengthening, the uterus raised the abdomen. But there are two mechanisms of the delivery of the placenta: the Duncan mechanism, from the edge of placenta separate first, and of course the picture stands for the two mechanisms, which is Schultz mechanism and Duncan mechanism. As we see, the Duncan mechanism starts from the edge of placenta and to the rest of placenta, while Schultz mechanism starts in the middle of placenta and tears or it's separated from the uterus from both edges. Of course, we have to prevent postpartum hemorrhage by using oxytocin and control traction and uterine massage. But if the placenta is delayed from being separated, we have to do a controlled cord traction by what's called Brand-Andrews method, as it's shown in this picture. The one hand pushing the uterus and with the left hand pushing the uterus and doing massage of the uterus. The other hand is a controlled traction of the cord. You have to examine the placenta, of course, for other parts or certain congenital anomaly like bipartite placenta or bilobate placenta, and examine the perineum and repair of the episiotomy. Before discharging patient from delivery, we have to check the uterus, and we have to ensure it is already contracted, and the introitus for any tears or bleeding, and we have to check for any towel may be left in the introitus. We have to check of the bladder by doing catheter and the baby. Thank you.